Hello, everyone. Welcome to tonight's Connecting the Dots in Ehlers-Danlos syndrome with Dr. Chopra. We are very honored to have him here with us tonight. So with that, I will turn this over to Dr. Chopra, and Kendra Nielsen Myles of EDS Wellness will be moderating for us.
All right. And Dr. Chopra, I know that, thank you for being here with us. It's great to see you again. I've always loved working with Dr. Chopra, and he's such a wealth of information and a resource for our community. So I'm going to read a short bio real quick and then hand it over to you. Does that work, Dr. Chopra?
Yeah, that's fine.
Okay. Dr. Chopra, he is currently the director of the complex conditions. He is currently the director of the Center for Complex Conditions. He completed his training in anesthesia and critical care with a fellowship in pain medicine from the Harvard Medical School. Currently the assistant professor clinical at Brown Medical School. He has a special interest in chronic complex pain conditions and their associated coexisting conditions. He has several publications to his credit and is on the editorial board for a journal on pain, serves as the medical advisory board for several chronic pain conditions, former chairman of the EDS International Pain Consortium, national awards, including Compassionate Care Award, Lifetime Achievement Awards, and Humanitarian Award. And with that, I will turn it over to Dr. Chopra. Thank you, Dr. Chopra, for being here.
Thank you, Kendra. Thank you, Daniel, for inviting me. I hope you guys can hear me, right?
Yes.
Okay. All right, so let's get this started. So connecting the dots in Ehlers-Danlos syndrome is not that easy. It's a very, very complex condition because the tissue affects every single part of the body. And so no two Ehlers-Danlos syndrome patients are the same. And so it's kind of hard to make a presentation that'll cover everything because that can take days. So the hard part was removing stuff that I thought would not be, rather focusing my presentation on the more common conditions and common questions that I have. And you guys had sent in some questions that I have incorporated in here. So this is just a disclosure. This is a disclaimer. So I have no conflict of interest in any of the products that I show or anything like that. A lot of this will be off-label use of medications. And this presentation is for general information purposes only, but you have to talk to your physicians for your particular treatment. So the important thing to remember in EDS is that there are three things. One is the tissue is weak, the connective tissue is weak. So what is connective tissue? Think of the human body as a skeleton. And then everything is connected on it. So I have muscles, ligaments, all of these things plastered onto me, and they connect my different parts of my body. And so it's called connective tissue. Connective tissue in me is kind of stiff, which brings me my own set of problems. But connective tissue in EDS is softer, which brings its own set of problems. But I do need you to understand that EDS is not a disease. It's a form of the human body that has its own has its own issues that we need to understand. One of the problems with this is it leads to poor joint position sense. I'll explain all of this later on. It also has some coexisting medical conditions like dysautonomia, mast cell activation syndrome, headaches, spine problems, and all sorts of things. Here's the thing. It is important to understand the cause of the pain before deciding on treatment options. So very often I'm asked, what's the treatment for pain? And it makes no sense to me because, your pain could be from a small pinprick, or it could be from a bullet injury in your head. And the treatment is going to be entirely different. So it doesn't make any sense. There's no treatment for pain. The treatment for pain is to treat the cause of the pain. For example, if you look at the shoulder joint, now somebody can have pain in the shoulder joint from a dislocated joint, or you can have it from muscle spasms, or one of the blood vessels or the nerves could be impinging or damaged. It could be any of the above, it could be all of the above. But depending on what the problem is, you have to treat them accordingly. So if it's from muscle spasms, so we treat the muscle spasms. If it's from a dislocating shoulder joint, we treat that. So there's no universal pill that will take care of all of these. Similarly, on the treatment point of view, there's no one treatment, but what I call is the 10% rule. The 10% rule means that you can use one modality and get 10% benefit out of it. You can use a second 10%, a second modality and get 10% out of it, and so on. When you have 5 of these, you get 50%. So in case of this knee problem, well, maybe stabilizing the knee with braces will take away 10% or 20%. Strengthening the muscles around the knee will help. Medications might help. So these are some of the things that we have to look, and our expectation is 50% relief. It's not as much as even the relief, as much as function. So, a lot of us function with pain, and it's only when you can't function, then we start worrying about the pain. So I'm going to start from the head. Head pain. There are many, many reasons why people with EDS have head pain or headaches. One of the migraines is one of the most common reasons, and I don't know if it's more common because EDS shows up more in women, or because we don't know what the connection is. Chiari malformation, we'll talk about that. Pain from muscles that connect to your head, which is called cervicogenic headaches. Pain from the temporomandibular joint, so these muscles, when they go into a spasm. POTS can cause headaches. Tethered cord can cause headaches. CSF leak can cause headache. So CSF leak causes low pressure inside the head. So when the pressure in the head drops, the brain drops, and that causes a headache. Instability, the neck, craniocervical instability can contribute to it. And something called idiopathic intracranial hypertension, which means increased pressure inside the head can cause headaches. I'll touch a little bit on each one of these. So if someone comes and says, my whole head hurts, and I have a double vision, and then I have this throbbing in my ear, and my headache increases when I laugh or cough. Now, this is a kind of a tough pain. Patients with this is pain from intracranial hypertension. That means the pressure inside the head is increased. And these patients present with, it's almost like their head is going to explode. And I call it an exploding pain. So the pressure inside the head is raised for different reasons. And you have to, again, like I said, find what's broken and treat it. And finding what's broken and treating it is the issue here. So these patients present with double vision. They have a pulsatile ringing in their ear. It throbs with their heartbeat. Now, the common reasons for having intracranial hypertension is a narrowing of the blood vessel inside. So what that means is there's blood going into my head and there's blood coming out of my head. And obviously, the amount that goes into my head has to be the same as the amount coming out. But what if the blood coming out of my head is not as much as the blood going into my head? That would cause an increase in pressure. And that's caused usually by venous sinus stenosis, or narrowing of one of the veins. It's usually treated by a stent. Or Chiari malformation can cause headaches, increased pressure headaches, and I'll show that to you in a few minutes. The diagnosis is not a spinal tap, and that's the reason why I put it in there and I crossed it out. Spinal tap is not a diagnostic reason in this case. Eye exam is also not something that I would wait for it. Yes, you do need an eye exam to see if it's affecting the optic disc, but I've had doctors say, oh, your eye exam is normal. That means you don't have an intracranial hypertension. That's like shutting the barn door after the horse has left, which means the pressure inside the head has increased so much that it has caused a damage to the optic disc. So we don't wait for eye changes to happen. MR MR venography means they inject a dye and do an MRI of the head to see if there's any stenosis. Upright MRI in case of Chiari malformation. And finally, the diagnostic gold standard for diagnosis of intracranial hypertension is to use what is called a subdural bolt. So, I mean, I know it sounds like it sounds weird to call it a bolt, but basically it's a transducer they put in the shallow part of your head, and it monitors your pressure in there. And I'll explain to you why later on. The problem with the spinal tap is that the bag in which the fluid is, let me show you this. So this is where the CSF, give me 1 second, let me pull up a laser. So this is your CSF in there, flowing in there, right? It's closed. And when you do a spinal tap here, it makes a hole in the bag that's holding the fluid. There are two issues with that. The wall of the bag is thin in EDS. And so you can't get an accurate reading. The second problem is you're left with a leak, which leads on to post-dural puncture headaches. The other thing is that let's say a patient has raised intracranial hypertension from a Chiari malformation. So there's a block over here at this level. Now, the pressure inside the head is not the same pressure inside the spine. So if I measure the pressure in the spine, it may show up as being normal or low even. It's putting a bolt in the head that gives you the most accurate reading of what the pressure inside the head is. So going back to it, a spinal tap is not something that we recommend, but a bolt is the way to go. You usually get admitted, they put this bolt with a tiny numbing medicine, they give you a little bit of numbing medicine, put that bolt in there, and they monitor you for, I believe, 24 hours. The treatment lies in medicines to decrease the fluid pressure, obviously. You can do a VP shunt, a ventroperitoneal shunt. There are many different types of shunt to decrease the excess fluid. They can put a stent where the vein is stenosed, or finally surgery for Chiari malformation. A different type of headache is, it gets worse when I stand and it almost goes away when I lie down. I'm so sorry. When I lie down, well, it does go away when you die, but let's leave that for another day. So my headache gets worse when I stand and it almost goes away when I lie down. Almost meaning that it pretty much goes away, not gets better. It should be. So my question for my patients is it 80% better when you lie down? And if the answer is yes, that's when I know that this is a CSF leak headache. So when they stand up, so again, let me show you this. What happens is the CSF is in a closed compartment here. It starts to leak out. When it starts to leak out, the brain kind of drops down. It's actually called a boggy brain. You can see it on an MRI. It's called a boggy brain. The brain kind of hangs down. And that causes an intense headache. It's a pretty intense headache. And it gets worse when you stand, but it almost goes away completely with lying flat. These headaches are usually in the back of the head, but if it becomes severe, it can be the whole head. But it is not an exploding headache. That's what I was trying to explain. So how do you treat CSF leak headaches? Hopefully it's a small leak, so you increase your oral fluids, drink plenty of fluids, take some caffeine. Now, the best way to take caffeine is Excedrin migraine. That has a boatload of caffeine in it, and that helps. You don't want to be taking coffee or tea, because then that makes you pee a lot more, so you drop your fluids even more. A corset or an abdominal binder helps, so you tighten it on your belly, and so it raises up the pressure. They can do what is called an epidural blood patch, or if not, an epidural fibrin glue. Oftentimes, when it happens after surgery, the tear is too big to repair by itself, so they have to go in and surgically stitch it up again. Another headache is the headache gets worse when I cough, and I get this tingling in my hands and feet, and I have difficulty swallowing. So coughing makes the headache worse. It's like coughing, laughing, and it's like you have a headache and you suddenly laugh and you get this, ow, that hurt. And it causes tingling in your hands and feet and difficulty swallowing. These are symptoms of Chiari malformation in terms of headaches. So what is Chiari malformation? On the left side is a normal cut section of the brain. And at the back of the brain, so this is the back, this is the front. This line over here is the hole through which the brain comes out and becomes a spinal cord. So this is called the brain stem. So think of it like a flower. This is the flower part, and this is the stem part, and this is called the brain stem. This cauliflower-looking organ is called the cerebellum. The cerebellum is responsible for balance, coordination. That's its job. Now, what happens in Chiari malformation, for various reasons, the entire brain starts to push down through this hole called the foramen magnum. And so everything gets tight. So the hole, everything gets jam-packed into it. It sort of corks into that little hole. So the brainstem gets compressed. So does the cerebellum gets compressed. Now, so that's where you use logic to find out, okay, if the brainstem gets compressed, what's in the brainstem that would be a problem? The brainstem has many things in it. One of the things it has is it's that center which controls your blood pressure and your heart rate. So that can trigger your POTS. The cerebellum gets compressed, and I told you the cerebellum is responsible for coordination and movement. And so that goes haywire. So here we are. On the left are the common features. The headaches get worse with coughing. So I'm sorry, going back there, because this hole is corked tight, now the fluid, the CSF fluid that's produced in the brain can no longer go into the spine. So it's kind of stuck it there, which expands and expands and expands till you get symptoms of intracranial hypertension. So the headache gets worse by coughing or straining. They also have neck pain, balance problems, like I explained, tingling in their hands and feet, dizziness, difficulty swallowing. All of these are part from, well, the dizziness is the POTS. Difficulty swallowing, again, this is a brainstem issue. And then they have poor hand coordination, which is again from the cerebellum. So medicine is a very logical subject where you have to see what's the problem. Now, obviously, no one is going to come to me with, Chiari malformation tattooed on their head, but they're going to come to me with these symptoms, and I'm like, okay, so these symptoms, what are the reasons a person can have these symptoms? And then you sort of rule them out one by one, and eventually you might wind up with Chiari malformation. How do you diagnose Chiari malformation? Obviously, a really good history and physical examination. So asking a proper question, the right questions, and doing a right physical exam helps. They do recommend getting an upright MRI of the neck in patients with EDS. So what happens is, when people with EDS, when they stand, there's a cranial settling. So the entire head kind of settles down. And that may produce a picture of Chiari malformation. It may go away when you lie down because there's no pressure on that area. So an upright MRI of the neck is extremely important in these cases. Temporomandibular joint dysfunction, believe it or not, as simple as this joint is, it's an annoying pain. It's an annoying, and I think pretty much 99% of my patients have this. So, and this is not just EDS, this is also non-EDS patients. what happens is that these are the chewing muscles. This is called the masseter. This is another chewing muscle, a grinding muscle called the temporalis. And so what happens is most people with with TMJ dysfunction tend to grind or clench their teeth a lot, maybe because of pain, maybe because of some habits, but they do tend to clench a lot. What happens is that these muscles get tired and they hurt, and they're being, not only are you clenching all night, and then during the day you talk, you eat, so these muscles are constantly being used, and then they get painful, and when they get painful, it triggers a headache. So this is a very, very common reason for headaches. The good thing is that it's relatively easy to treat. Now, a TMJ pain can spread down the neck into the upper back. So one of the methods to treat it is you can do a gentle massage. So what I recommend is putting a heat pad over here, wait for the muscle to sort of soften out, and then put your two fingers, put your thumb in there and your finger in there, and you sort of gently massage it, gently massage this muscle over here. You can have a doctor do trigger point injections into the muscles. You can even have somebody do Botox injections into these chewing muscles and the grinding muscles, and that makes a huge difference. The expensive way is to treat it is to go to an orthodontist who then makes what are called oral appliances, and those are custom made, and they put them in your mouth, and you do put them at night or during the day. So when you clench, you're clenching on air. That's the reason I didn't put that in, it's because it's literally impossible to find a good orthodontist who understands EDS and TMJ. Upper back pain. So there are lots of reasons for having upper back pain. So the muscles that control our shoulders live in our upper back. When I say upper back, I mean this part. They live there. Ribs sublux, and subluxation of the ribs is a very excruciating pain. POTS can cause upper back pain. It's called a coat hanger distribution. So imagine your hanger, like the hook is the neck, and then it goes down and it spreads out over here. Obviously, like I said, again, treating the cause of the pain. So in this case, I would say, all right, let's treat the POTS, and that might help with the coat hanger pain. In women, it can be the weight of the breast tissue. So heavy breast tissue can then drag you forward, which the muscles in the back have to work extremely hard to pull you back into an erect position. So these are some of the reasons why people have upper back pain. Obviously, you want to correct the POTS. One of the things you can also do is wear a sports bra with a racer back. I have some pictures later on, I'll show you. A sports bra with a racer back that sort of holds, the idea being that it'll hold your shoulder back. And normal bras usually don't do any supporting work. They just sort of give a lift. But sports bras sort of hold you back. Or a compressive vest to support the spine. So because of the laxity of the ligaments of the spine, people with EDS tend to sort of slouch down. And when they slouch down, then the back of the muscles start to hurt. This is a company that I came across, DM Orthotics, and they've been making compressive clothes for people with I forget. They've been making clothes, compressive clothes for many, many years. And they've recently, about a few years ago, they started making them for patients with the EDS. These are excellent for people who've tried them. They're excellent. They do work very well. Worth a look at them. And depending on how or where your pain is, you can, if it's on one side, both sides, different sizes, you can try that. There are other companies that make them. These are ones that I picked up from a company called Leonisa and a company called CW-X. I think these pictures are from Leonisa. Leonisa is a company that makes bras for women who have had, they started out making bras for women who had breast issues, breast surgery, and now they've sort of gone on to making them for athletic uses. So this is another nice racer back you can see, and it's very supportive. I'll show you CWX in a few minutes. Neck pain, we know that the neck is a collection of vertebrae. There are 7 of them, and they're kind of stacked on top of each other, and they're really delicate little vertebrae. But the problem is that on top of that, so if this is my spine, the head rests on top of that, and the head weighs the same as a bowling ball. Now imagine a bowling ball. The analogy would be a bowling ball at the end of a pin. And so it tends to roll off. And when it tends to roll off because the ligaments are loose and lax. So what happens is the muscles tighten up and bring the head back, which is fine. But the problem is that by the end of the day, you're sort of sitting, supporting your head like that. You can't take it anymore, or you're just lying back, supporting your head because the muscles are just tired of holding up the head all day long. So that's another reason for having neck pain. And that's besides having instability of the spine. So this is what I just explained. So oftentimes I don't recommend resting your head on your chin on your hands like this, because it's fine. The problem is that it can trigger your TMJ, make it worse. But a supportive neck collar will help. And if it's not too bad, then you can use a soft neck collar. If you need to use it at night, for example, you can use one of those inflatable neck collars that they use on airlines. And nowadays they make them really good, so your head is well supported, it doesn't roll off, and you can inflate them to your exact size. Now, just to be clear, you don't have to wear the neck collar all day long. You just wear it towards the end of the day when your neck is beginning to hurt a lot. Craniocervical instability, I told you how the head and neck are all stabilized by ligaments. Unfortunately, these ligaments are like elastic bands. And so whenever you stand, the ligaments don't do a good job. And so what happens is the head sort of settles down. And again, when it settles down, it causes what is called Chiari malformation. Actually, the term is false Chiari malformation, but it does that. The imaging for craniocervical instability is not a static picture. I've been trying to tell people for the last 30 years, it does not help to take a static picture. It means you go there, you go to the radiology department, you lie down straight and flat, and they take some pictures, and then they come back and say, well, we don't see any instability. Yes, you don't see any instability because you're not having them move their head. So we need a functional CT scan, which is you have your head flexed, and then you have it extended, you have it rotated to each side, and then we combine all these pictures and you see how much is the vertebra moving. Or even better, you can do is a digital motion X-ray. It's a kind of a light X-ray, and they actually get a video of you moving your head, and then they can exactly see which vertebrae are moving in which directions. So each of these two are amazing devices. But I want you to be, the reason for this slide is I want you to understand is getting a static picture, and I get this a lot, is not helpful for diagnosis of craniocervical instability. Let me give you an analogy. Let's say the tire, one of the tires on my car is loose, it's wobbly. It's parked outside on my driveway. I have no way of knowing which tire is wobbly, which one is loose. I won't know it till I drive it. Till my car moves, I will not know which tire is wobbly. It's the same thing here. Until you don't move your neck, we won't know which vertebra is going which way. The treatment is, you can try strengthening exercises for the neck muscles, which I don't think is, depending on how unstable it is. If it's not a lot, then strengthening exercises might help. But if it's a lot, then it won't. you can wear a collar, a cervical collar. What it does is it sort of, the collar takes the weight of your head off your neck. And so it transfers the weight onto your chest. And so that gives your neck a little rest. And then, of course, in severe instability, consider surgical fusion. Now, on cervical fusion, there are two schools of thought. One thought is that let's put a traction on the head. Okay, we put a traction, we put a pulley up there, and we put weights, and the head gets pulled up. And at some point, as they add weights, at some point, the patient starts to feel better. And generally, they look for an 80% response. Now, if they get an 80% response with no other problems, that makes them candidates for surgery. Now, the weight that they used, let's say 30 pounds, was when you got the best response. So that means that when the neck gets pulled to that level, that's when you get the best response. So when the surgery is done, the patient is under anesthesia, they put the same traction with 30 pounds of weight, and it's then fused in that position. The best analogy I can get you is when you use super glue, you want to make sure that the two pieces don't move. You have to find the best position and just hold it like that, and then wait for the super glue to fuse it. It's the same philosophy where you put a traction on the neck, and then you find the best position, which is giving you the most relief, and then you fuse it in that position. I do understand doing an invasive cranial traction is a little bit of a process, but it's actually for patients who have true craniocervical instability, it's actually not that bad. But it makes logical sense. That's the idea. Other surgeons believe in looking at your MRI left and right, and then they see, okay, the C3 seems to be moving on C4, let me just fuse it. But that's not the optimal position at which it's fused. It's fused at, it moved a little bit, and that's where it is fused. So these are the two schools of thought in terms of cervical fusions. This is a type of a neck collar called the Vista multi-post collar. And what it does is it takes the weight of the head and transmits it to the shoulder, to the chest. This particular brand has a little cushion that you can inflate. You press a little black button, it inflates it and sort of adjusts. It's adjustable. This is adjustable in a million different ways. The other one is the Miami J collar, which is also a really good collar, and it supports the chin at the same time. These are some of the collars. So basically a neck brace, what it does is it takes a load of the head off the spine. It does not weaken the neck muscles. That is a misconception, because you can still turn your head and use your muscles. It in fact frees up the neck to be able to use properly. So the concept that neck braces make neck muscles weak is incorrect. One of the questions I was asked was about prolotherapy. I don't think it's a good idea in EDS. So let me explain why. Prolotherapy is what they do is, the idea being because your tissue is loose, your ligament is loose, let's go in there and irritate the tissue around it a lot. And so they inject a glucose solution or some other chemical that causes irritation. That irritation causes scarring. So it's like a bunch of injections they give you there. So that causes scarring. But here's the problems. The scar tissue in EDS is actually weaker than the original tissue. So you're actually making the condition worse. It does help for a short period of time, but eventually it gets worse. So the benefits are very temporary. Facial pain, I wanted to address this because I see this as a misdiagnosis a lot. These are, so what I'm talking about is called eagle syndrome. Eagle syndrome, it doesn't have anything to do with the bird. It's the guy who found out his name was Eagle. just so you know. It is often misdiagnosed as trigeminal neuralgia. Oh, you got pain in your face, it must be true trigeminal neuralgia. Again, there's no logic behind it. There's no studies behind it to prove that this is trigeminal neuralgia. You just go to a neurologist or a doctor and he says, oh, you got pain on your face, it has to be trigeminal neuralgia. That's not always true. This pain is a sharp nerve-like pain in the jaw, and it goes into the back of the throat and the base of the tongue. Now, the trigeminal nerve does not go into the back of the throat or the base of the tongue. And so this is a severe pain. It's actually a very painful condition. It's severe pain in the jaw, goes back into the back of the throat and the base of the tongue. The pain gets worse with swallowing or moving the jaw as you talk or in turning the head. So if you turn your head this way, this pain will get worse. Why does that happen? So this is a cutout from the side of the face and head. And this little pointy thing over here is called the styloid process. And you can see that there's a bunch of nerves that go into the throat, into the face, into the jaw. And this is it's a tiny, it's not that big. It's about this big, tiny little thing. But in Eagle syndrome, for whatever reason, this fellow starts to grow and grow and grow and grow and become bigger. When it starts to grow that much, it starts to compress nerves and blood vessels. And that's the reason for the pain. So it's an elongated styloid process that causes Eagle syndrome. I diagnosed a young girl with Eagle syndrome, and she went to a hospital in New York, and none of the doctors had ever heard of it. They all went and Googled it, and they all came back and poked her till she was in excruciating severe pain because they all wanted to see what this weird thing Eagle syndrome was. Numbing medicine. So this was somebody who posted this question. The common numbing medicine is lidocaine, and oftentimes it's ineffective. And the way you know it's ineffective is you need more, or it takes longer to work, or it doesn't work at all. But the ones that work best are Marcaine or Carbocaine. Now, Marcaine is very freely available. Most doctors who do this stuff, like dentists and surgeons, will have Marcaine. And if you don't know whether your lidocaine works for you or not, if you know for sure, it's not a problem. If you don't know, just ask. If you're getting a procedure under numbing medicine, just ask for Marcaine. It's best to call the facility beforehand, call the doctor's office ahead of time and say, look, lidocaine does not work for me. Do you have Marcaine or Carbocaine? And if you don't, could you please order some for me for that procedure? And it's not a big deal. Most places have Marcaine. The problem right now is that there's a national shortage of both lidocaine and Marcaine. It's on back order for the last year. Tethered cord syndrome. This is a picture. So on the left side, forget the right side. Look at the left side, and you're seeing a section. If I took a knife and I sliced the spine, and you can see this is the spinal cord. This is the bony part of the spine. So this bony part of the spine is like a bony tube. And the spinal cord comes down and generally ends at L1. So where is L1? L1 is approximately the level of your bra strap. Approximately. That's how high L1 is. And that's where the spinal cord ends, at L1. After that, it becomes a thread. It's a useless piece of thread hanging over there called phylum. It just hangs around, does nothing there. There's a whole embryology reason for that, but it just hangs down. And in children, when they start to grow, the spinal cord moves. As the spine grows longer, the spinal cord also moves up. In adults, as who've stopped growing any taller, as they bend forward or move around, it moves with them. So there's no tension on the nerves. The nerve tissue, like the spinal cord, is very delicate tissue. And there's nerves that are coming from the sides of the spinal cord that go to different parts of the body. And you don't want them to be under tension. In tethered cord, what happens is the phylum is stuck to the bottom of the spine. And so it pulls on the spinal cord. So this cone is called the conus, the end of the spinal cord, now ends at L3. And this is under tension. So the entire spinal cord is under tension. These patients with tethered cord syndrome can present an amazing variety of problems, There are so many of them that we don't know all of them yet. We've been surprised when they get the tethered cord surgery, we've been surprised that, oh, this got better and that got better. But in general, they have back pain, which cannot be explained by any other reason. They have something called a neurogenic bladder. I'll explain that to you. When they walk, their legs get heavier and heavier and heavier. They also have pain in both legs or one leg, but it's not in any specific distribution. It's just a diffuse pain. They also have Charlie horse-like cramps in their legs. So back pain, neurogenic bladder, and this heaviness and Charlie horse-like pain in their legs. Oh, so I just repeated the thing again. So a neurogenic bladder is when they have urinary hesitancy. They usually have increased frequency, so they go a lot. They have urgency, can't wait. They have a sense of incomplete emptying of the bladder. So they've just peed and it still feels like there's some left. They're not sure, they're hesitant. In some cases, it might be even incontinence. Now, just to be clear, incontinence in women, this is not the incontinence that you get from laughing or sneezing, but this is incontinence that happens with no straining. But generally, what I see is a lot of urinary hesitancy, increased frequency, urgency, and sense of incomplete emptying of the bladder. Here's a catch. People with EDS who have Chiari malformation should also be checked for tethered cord syndrome, because approximately 60% of patients who have Chiari malformation also have tethered cord syndrome. And we don't have any scientific data on why it is there, but we know it's about 66%. Now, here's the thing. An MRI is not a useful tool for diagnosing tethered cord. It may or may not be. Most radiologists miss it. They don't care for it. But it's usually not a useful tool. But you do need an MRI because they want to rule out any other problems. The diagnosis is based on clinical history and examination. They do need a urodynamic study, which means you go to the urologist and they do a study of your bladder to see if you have a neurogenic bladder. A neurogenic bladder means that the bladder is not talking to your brain. So your brain doesn't know when it's time to pee, and it starts to, when it's empty. So that's called a neurogenic bladder, and they do a urodynamic study. So combining all of this information helps the surgeon decide whether you have a tethered cord syndrome or not. The good news is that the bladder symptoms improve pretty much the day or the other day of the surgery. It's pretty fast. The leg pain takes about approximately 6 months to a year to improve. But we've had surprising results. We've had patients whose neck pain have improved. We've had patients whose GI issues have improved. And so we've been surprised by this. I just had a 16-year-old go through a tethered cord syndrome. She had terrible GI issues. And she also had a tethered cord. So the tethered cord surgery was done. And by a week, her GI symptoms had all gone. So we don't even know what improves when you get tethered cord syndrome, but we do know a lot of things get better. Subluxations and dislocations, I really want you to understand this. A subluxation, so all joints are made up of two bones, okay? And in a subluxation, the subluxation is the same as the slippery bones. The bone slips out, slips back in. You can do it 100 million times a day, slip in, slip out. In a dislocation, the joint comes out and it stays out, and then you have to literally push it back in. The reason I brought this up is because in a dislocation is obviously a far more serious thing because there's been some tissue tear and damage. So you can see that over here, how the capsule has torn up, whereas in subluxation, it has only stretched. Now, the problem with when a joint subluxes or dislocates, it's not from the joint itself, it's from the muscles around it. So when say if my shoulder joint subluxes, the pain that I get is because my rotator cuff muscle goes into a spasm and it's trying to stop it from subluxing. Now, here's the problem. If you may go to a physician and say, look, I have this pain in my shoulder joint, and they look and say, yeah, you've got muscle spasms. Let's just treat the muscle spasms. The problem is that it's those muscle spasms that are keeping your shoulder joint in place. If I go in there, loosen up these muscle spasms, then you're going to start to sublux even more and even dislocate. So the muscles are spasming for a reason. And you don't want to take away that. You don't want to just take away that protection you're getting from muscle spasms. In subluxation, it happens from this capsule being stretched. It's not the bones rattling against each other. That's not the reason for pain in subluxation and dislocation. Rib pain, this is an awful, awful pain condition. And so I really want to, it's bothered me for years in terms of how to find a solution. So rib pain, there are two types. There's the rib subluxations, and then there's costochondritis, and we can forget costochondritis. Let's talk about rib subluxations. Each rib connects to your thoracic spine by a joint. So there's a joint, actually there are three joints. Each rib connects to your thoracic spine by three little joints. And remember that all ribs have to connect, and they are joints because the ribs have to move up and down. So you do need those three joints to keep the ribs stable. What happens is that people with EDS tend to have a slouched posture, and that's because their ligaments are loose and they tend to stoop forward. And especially in women with heavy breast tissue, they stoop even forward. So when the thoracic spine starts to bend forward, it pops that rib out. So imagine this is my thoracic spine and the rib is connected to it. Let's call this my rib, and it's connected to it. And as the spine starts to slouch, this rib pops out. And that causes pain to go around. And that's the problem in cases of, that's the reason for this rib subluxation. Now, putting the rib back in place is fine. It'll only give you temporary relief, but we need to prevent it. So let's talk about what happens when you actually have a rib subluxation. You can use one of these rollers. It's a hard rubber roller, and you roll right over that area, and that pushes that rib back in, pushes the rib back in. The rib pops backwards. So you push on the rib and it goes right back in. So that's when you have an acute subluxation. But the other things that you can do, like a cat stretch, I'm not so convinced if that helps or not, but you can try it. But what prevents it is to wear a compression garment. And these are, again, I've shown you from DM Orthotics. These compression garments, what they do is they sort of tend to hold the spine in a more stable position. It won't stop you from subluxing, but it'll stop you from subluxing too often. It won't sublux as often. So this is based on the theory of joint position sense of proprioception. So these compressive garments provide joint position sense, and patients tend to keep their spine a little more erect, and so they don't curve forward and the rib pops out. There are other companies that make it, and I'll make similar stuff, and I'll show you those at some point. Shoulder pain, it happens usually when the shoulder joint is unstable, which then causes the muscles around it to tighten up. But one of the other reasons is arm pain that comes from the shoulder. And I'll show you why. So sometimes patients complain of pain or tingling down their arm and into their fingers, and it looks as if it's coming from the neck. But in reality, it is not coming from the neck. What's happening is, this is the front of the chest. And over here, you have the ribs. So these little things are ribs. You're looking at somebody from the front. This is the collarbone that goes across it. So when your shoulder joint is loose, the collarbone tends to move. And when it moves, it pinches the nerve that goes down to your arm. And at the same time, this muscle, which is called the pec minor muscle, goes into a tight spasm, which again pinches the nerve going down the arm. So imagine this is your first rib, which is a flat rib, and this is your collarbone. And between the two, you have the nerve that goes down your arm. And what happens is when the collarbone, because the shoulder is loose, the collarbone narrows the space over here, pressing on the nerve, and they get this pain. At the same time, the pec minor muscle goes into a spasm because the shoulder joint is loose, and that pinches the nerve again. Now, the purpose of me talking about thoracic, actually, believe it or not, in a lot of the cases of thoracic outlet syndrome and EDS, it's not a big deal. There are a few cases where I've seen it's a big deal, but in general, it's not a very, very big deal. But I want you to know this is because I don't want somebody saying, oh, you've got pain and going down your arm, it must be coming from your neck. Let's do an MRI of the neck. Or there you've got a disc bulge. Let's go and do some surgery on your neck. That's the reason why I'm trying to educate you on this. But if you do have thoracic outlet syndrome, some of the treatments are kinesiotaping. Botox injections work amazingly well. In almost 70% cases, the Botox injections work well. What I do is I inject the pec minor muscle so as to loosen it up. I inject this muscle called the scalene muscle that loosens it up. If all else fails and if the pain is excruciating, then you go in for a surgical correction where you stabilize the shoulder joint. This is an example of kinesiotaping. If you can tolerate kinesiotaping, if you can tolerate the adhesive on the kinesiotaping is a very good way of treating joint pains. And it's very easy. You can buy some of it off Amazon, go on YouTube. There are excellent videos on how to kinesiotape. You can talk to your physical therapist. They can show you how to kinesiotape, and they do work very well. Let's talk about joint position sense. Joint position sense is where there are sensors in my joints that tell my brain exactly where my joints are at any given time. And so my brain constantly knows where my joints are at any given time, and the brain then uses that to compensate. So for example, if you're walking, your brain knows exactly how high your right leg is, sends a signal to your left leg. You're walking up the stairs and your brain knows exactly where your right leg is. Is it 6 inches? Each stair is 6 inches. And then you go and you go upwards. Oftentimes, because there's poor joint position sense, because of joint issues, your brain doesn't know that you've crossed 6 inches. You crossed only 4 inches, but your brain thinks it's 6 inches, and you trip forward when you're walking up the stairs. So that's from joint position sense. And it is protective. It helps us understand. It protects our joints. It protects us from overextending our joints, and it's common in patients with EDS. So this is another picture I wanted to show you. The signals go up from here into the spinal cord to the brain, and the brain then in turn communicates to the rest of the body as you walk or as you move. I'm sorry, I keep getting DM orthotics, but I do have other companies. Same thing. So how do you treat joint position sense? There are a few ways, but one of them is that if you wear something that is compressive, that presses over the skin, over the joint, then, for example, hands. If the hands are, if you have hand pain from poor joint position sense because you hold your pen too tight or your knife too tight, then you wear a compressive glove, and the touch of the fabric on the skin over the joint gives the brain a sense of where your joints are. So this is again a company that produces a lot of these sensory clothing for this. This is another company. It's a sportswear company actually called CWX, and what they do is this is incredible. What they've done is they've created something like an exoskeleton. So they've reinforced where your joints are supposed to be. They've reinforced these. It's like having kinesiotape built in, and this really makes a difference. So it's compressive with reinforcement of the joints, almost like an exoskeleton, and it gives a lot of support to your legs and muscles. They do make, I think they make clothes for the upper body also. Plus, I think they look really cool. This is a company called Leonisa, and they are more known for their bras. And they do also make other stuff, but as far as we are concerned, we're looking at the bra. Having a bra strap that kind of is a cross, like I talked about racer back. This is an ideal one. And look how it takes the load off the back. You can buy a sports bra with a racer back at the local dollar store, but the difference is in the quality over here, is how they design this. And so it's worth looking at that, especially in patients who have shoulder subluxations, rib subluxations. This is a very good way to go. Hand and wrist pain is again the same thing. What happens is when you hold something, because there's no signal getting from your knuckles, you tend to hold your pen too tight, or when you're cooking, you're holding the knife too tight, or stirring, you're holding the handle too tight. And so your poor hands, these little muscles in your hand are getting tired and they get painful. Again, the treatment is to wear something like this, a fingerless compression glove. Amazon, $10. They're sold as arthritis gloves, and they work very well. If you're writing, you can use a padded pencil. If you're cooking or something, you can use these. Now ring splints are useful for these three fingers, these two fingers and the thumb. These two fingers, the ring finger and the pinky, are just for show. They don't really do any work. So you want to make sure that if any of these joints are loose, stabilizing them with ring splints is the best way to do it. They're very easy, they're light, and they actually look good also. I recommend looking at this company called Zebra Splints. The person who runs it, there's a lady who runs this company. She makes them. The reason I said that is because you need to have a relationship with the person who makes your splints, because the size and thickness of your fingers change all the time. Sometimes you need them adjusted a little bit. Sometimes you need to be modified a little bit. And so it's very useful to have be in touch with her. In terms of utensils, OXO is a company. This is, again, I looked up a lot of these utensils and found out OXO is the best. They make their handles really thick and cushiony. And so you can buy these at Target, or you can buy them on Amazon. So they have thick handles. They don't need to put a lot of pressure on them. This is for pencils. You can get these on Amazon. So one of the things I get a lot of pushback from other physicians is, oh, don't wear braces. They make your muscles weaker. And that is absolutely not true. It's a misconception. The brace that you wear is around a joint. It's not around a muscle. So if you're wearing a brace around your knee joint, it's around the joint. It's not the muscle. Your muscle is still moving, number one. Number two, if I stabilize your knee joint, then you're more likely to walk. And that makes your muscles move even more. So effectively, braces make your muscles stronger and not weaker. Let's talk about pain in the lower half of the body. If your ankles and your feet are not stable, then that makes your knees unstable, which then makes your hips unstable, which then throws your back and your spine off. So very often, when somebody comes with lower extremity pain or lower half body pain, the first thing to look at is your feet and ankles. And there are two problems. The most common one is unstable ankles and flat feet. Flat feet is not that big an issue as much as unstable ankles, and I'll show you why. So this is a sample of an unstable ankle, and as you can see, this person is rolling her ankles as she's walking. When that happens, when they roll their ankles, there's a nerve at the end of below the knee joint. That nerve gets pinched. It's called the peroneal nerve. That nerve gets pinched. And what happens is each time this person rolls her ankle, that nerve below the knee joint, the peroneal nerve gets pinched. When that gets pinched, it produces pain down the leg and it causes a drop foot. So your foot becomes more dropped. You sort of, when you walk, you just skate over the floor. And if you've been walking for some time, you tend to stumble on your toes. That's the problem. In this case, rolling ankles is a no-no. The treatment is actually really simple, is to wear high top shoes with laces. So these are a pair of randomly, I picked them up, which I liked. So they have high top shoes with laces, and they should have some strength to it. I don't really recommend Converse, which is just basically tarp tied around your leg. But these shoes that are like hiking boots are great. Doc Martens are great. They're more stability to it, but they should have laces on them. Let's go up to the knees. So we've just stabilized the ankles, and the problem with the knees is that there's a hypermobile kneecap. So the patella goes around and slides around, and they hyperextend their knee joint. Now, between the two, hypermobile kneecap is not a big deal, but the hyperextension of the knee joint is a big deal. The reason I'm saying that is oftentimes when patients go to their orthopedic physician, he looks at a hypermobile kneecap and says, oh my God, you've got a loose kneecap, we should tighten it up. And then everything goes downhill after that. It does cause some pain. So this is just demonstrating a loose kneecap, but it causes some pain in the thighs. This is what we call as banana legs. The knees are so hyperextended, they're pushing backwards, and that's a no-no, because that really stretches these ligaments over here. And not only that, it puts a load on the hip joint. And so stabilizing the knee joint is extremely important. So once you stabilize the ankle joint, then you need to, and if you still have a knee problem, then you need to stabilize the knee joint. This is one brand of knee brace that I like because it wraps around. Instead of tugging it up, it wraps around your knee. It's by a company called Med-Spec, and it's called Gripper. Essentially, it has a hinge on both sides, and it prevents you from hyperextending your knee. It sort of keeps it straight. EDS in children. EDS, the most important thing in children is to start early. If you detect that they have hypermobility or they have EDS or a very strong family of hypermobility, then start early, because you don't want them to be overstretching their joints. If you overstretch their joints, you're never going to get them back. So they also have a very rough time during growth spurts. So they have bone pain, joint pain, their tethered cord pain gets, if they have tethered cord, then their tethered cord pain gets really bad. And so their growth spurt is awful. The problem with treating EDS in children is having ignorant hospitals and doctors. Unexplained bruises, dislocating joints, chronic body-wide pain, ignorant healthcare providers, doctors who have no clue what EDS is. It looks suspicious, so be careful about that. These thinks that these people say EDS is very rare, you can't have it. EDS what? Your skin is not that stretchy. So they get diagnosed with conversion disorder, or even worse, Munchausen by proxy, which is now known as fastidious disorder. They're often made by providers with no training. So you might have a medical student or a first-year resident who has no idea what left is from right, but he or she is good at diagnosing apparently conversion disorder. So got to be very careful about that. So how do you solve this problem? Check with other patients before you go to a hospital. Make sure that they don't have, number one, a child abuse specialist. This is a whole breed of specialists. And I don't know why they were done that. I think that these are all pediatricians who go into the specialty called child abuse specialists. And I think they must be probably the bottom of the class, and that's why they chose this specialty. If you sense that the doctor is skeptical of the complaints, just politely back out and go home. I would not take my child with EDS to an academic hospital, because the chances are that the first few doctors you're going to meet are interns and residents who don't even know what normal is, let alone what is abnormal. You don't want to go to a hospital on a Thursday or a Friday, because no attending shows up on no attending shows up on weekends. You're at the mercy of a resident or an intern. And so do not get admitted for whatever reason on a Thursday or a Friday, because nothing will happen over the next 4 days and you'll be mismanaged. If you're able, and if you can afford it, choose a concierge physician. These are physicians who you have to pay a small fee every month, but they are yours to help you out, and they are there to help you out in any way. It's like going back to the old-time physicians who were there for you at all times. Again, like I said, stay away from children's hospitals unless it's an emergency, or you definitely know that there is a doctor there who understands your child. Keep your pediatrician on your side. Let him update him or her on your child's health, because he or she is the one who's going to be fighting that battle for you if things go downhill. So definitely keep him or her informed. Again, I really want you to, I'm trying to drill this in your head. It is important to understand the cause of pain before deciding on treatment options. So there are lots of snake oil treatments out there. Oh, you just put this cream on and things will get better, or drink this fluid, or drink this liquid and your collagen will become stronger. None of that works. This is understand the reason why you have pain. POTS, the symptoms of POTS are get lightheaded when you stand. There's heart racing, fatigue, headaches, like I showed you. You also have cold hands and feet, which is often misdiagnosed as Raynaud's. They have lots of brain fog and a feeling of constant anxiety. The test for POTS is extremely easy. You can actually do it at home. Lie down flat for 5 minutes, take your blood pressure and heart rate. Stand up, immediately take another blood pressure and heart rate. Keep standing for 10 minutes, take another blood pressure and heart rate. If the blood pressure stays pretty much the same, doesn't change a lot, but the heart rate jumps up by 30 beats in adults or 40 beats in children, then that's significant for POTS. If it doesn't jump up, but you're still significant, you still have dizziness and heart racing, but the heart rate isn't really changing up to 30 beats, say, for example, it goes to only 10 beats, then it's probably orthostatic intolerance. The treatment is still the same. So it really doesn't matter whether you're orthostatic intolerance or POTS, the treatment is still the same. Some of the more fancy tests are Q-sweat test and then the tilt table test, which is a brutal test. This is the criteria for diagnosis of POTS. Why do people have POTS? And the reason I put this slide in there is because every specialty looks at POTS from their own specialty. So a cardiologist may look at it from a cardiac point, a neurologist from a neurology point, but no one looks at the whole thing. So one of the reasons you can have POTS is from blood pooling. So you're pooling blood down your legs, and that causes POTS, which is a long story. You can have POTS from craniocervical instability. Now, no cardiologist is going to diagnose you or look at even craniocervical instability, and that's the problem. You can have POTS from autoimmune dysfunction, or you could probably have POTS from median arcuate ligament syndrome or MALS. Now, this, I put a question mark because this we don't know for sure. It's kind of a question mark, but the reason I put it is because my patients that have gone for MALS surgery, to my surgeon that I like, have their POTS has improved. And so I always keep saying that there is a possibility that your POTS might improve. And it does in a lot of cases. I'm sorry, the presentation is getting a little long, but I'm trying to put in as much as I can. Now, what happens in POTS are also called dysautonomia, which is dysfunction of the autonomic nervous system. That means your autonomic nervous system, that is a system that controls your flight and fight, is revved up. And that's the same as feeling anxious. If you see a snake and you are now in a state of flight or fright, that is the same thing as feeling anxious. And so oftentimes people are misdiagnosed as having their problems as having anxiety when it's just a question of POTS. And the way you figure that out is you're sitting around, you're doing nothing, you're watching a boring movie on the television, and all of a sudden you get this wave of anxiety that passes through, and you're like, what happened? And that's a symptom of POTS. And when you have that, you right away, what you do is you take a tablespoon of salt and you chug it down with some water, you drink some more water, and that should just take care of that so-called anxiety. So management of POTS management, of course, will depend on treating these causes, the blood pooling, the craniocervical instability, autoimmune dysfunction, or MALS. But for the time being, the symptomatic treatment is to increase salt. Okay, so first try a salty diet. If that doesn't work, then take salt pills. A good brand is Salt Stick Vitacium. It's capsules that you can swallow easily. They also contain potassium, which you need. Electrolyte fluids like liquid IV, banana bag, drip drop, whatever floats your boat is fine. 16 ounces per day. Increase your water intake to about 2 liters per day. Compression tights, and I showed you some really nice, cute compression tights. You can try those. There is a medication that I really love, and that's called ivermectin. Ivermectin is my new miracle drug. It really helps POTS. One of the drugs that I don't like is being on a beta blocker. Beta blockers, in many cases, can actually make your POTS worse. And so I've moved away from beta blockers. Unfortunately, it's an ongoing battle because the minute they see your heart rate is high, your heart rate is high because it's trying to pump blood to your brain. And if I take a beta blocker and I slow down the pump artificially, then my symptoms of POTS get worse. So beta blockers are not a good choice, but this new drug, ivermectin, is a great drug to go with. Moving your muscles is extremely important. And so exercise while lying flat or reclining. Do not push yourself. All you need to do is pump your muscles and exercise whatever you can. If you can exercise for 2 minutes or you can exercise for 5 minutes, that's fine. A good place to find which exercises to do is to go on YouTube and you put in supine exercises for POTS. And there are people who have put in some really amazing videos. I would highly recommend looking at those. These are very simple to do. You could be having awful fatigue, awful brain fog, but you can do them in your bed, lying down, because that's the journey to getting better. Technology, I would recommend using Amazon's Echo Alexa set up in different rooms of the house. So if you need help, you've fallen down, or you can't go downstairs and ask for water or fluids or whatever, you can always use Alexa to communicate. You can communicate that with whoever is downstairs or elsewhere. You can, if you fall down or if you're lightheaded, you can call for help. Apple Watch after 4 has been excellent. It not only records your heart rate, but it has a fall warning in it, and it can detect a fall and call for help. And I just found out that the newer one actually has an accident warning also. So if you're in an accident, it can send a signal or a message to emergency services. So start using technology to help you with help make things a little bit easier for you. Mast cell activation syndrome is a painful condition. It feels like you have flu all the time. You're tired, you're cold, you're sick, and it definitely adds to your fatigue. It worsens POTS. This is a problem. But the most important part is it causes diffuse body-wide pain. Everything hurts, all your joints hurt, muscles hurt. Mast cells are found everywhere in the body, but when your immune system detects a danger, then it activates these guys, and these guys then release chemicals like histamine and cytokines that cause pain. Now, the problem is that in EDS, the immune system isn't quite up to its mark. These mast cells are just simply misbehaving, and we don't know for sure. I'm not going to go through this whole picture, but these are the systems it can affect. It can affect the brain, the heart, the GI tract, all sorts of things it can help. By the way, if you guys need a copy of the slides, just ask Daniel or Kendra and I'll send it to you. Or they'll send it to you, or post it maybe. So these are the symptoms it can cause. But what I do want you to understand is that it causes diffuse body-wide pain, joint pain, and GI issues. These are the two big ones to remember. Treatment is to start with antihistamines, famotidine, Benadryl, or Zyrtec. Mast cell stabilizers are drugs that stabilize these misbehaving mast cells, cromolyn, ketotifen, and quercetin. Ketotifen is sold in the US through compounding pharmacies, and the quality is not really that good and also very expensive. And if you can, get it from abroad. I think Canada probably has, yes, in Canada it is available as a regular drug, and it might even be cheaper. At least the quality will be better. Look for mast cell triggers that could be in in the foods that you're eating or in the air that you're breathing. So they could be mold in the house, they could be pollen in the house, the cat brought in something. Most people have it from cats, by the way. Dogs, not so much. It could be something in the duct system, in the foods. There is gluten foods, dairy, dairy. Oh my God. Gluten, dairy, meats. It can also happen from seasonings. So some of these are the things to look out for. Avoid drugs or food that have color dye, like especially red or blue dye. There's nothing more dangerous than having something that has a dye in it. These are some of the same things that I just discussed on mast cell triggers. Fatigue in EDS. This is a very short list of fatigue in EDS. So EDS itself causes fatigue, POTS, mast cell causes fatigue. The medicines that you're taking for treating fatigue can cause it. Pain can cause fatigue, poor sleep, or secondary mitochondrial dysfunction. Just going back to mast cell activation syndrome, I just wanted to point out, you're feeling, let's say, how do you differentiate between a POTS flare and a mast cell flare? So you're having a crummy day, and you don't know what's the problem here. Is it my POTS or is it my mast cell, or is it both? So you look at your heart rate, and if your heart is beating out of your chest, your heart rate is like 120, 130, and you're kind of feeling lightheaded and dizzy and panicky. That's your POTS. You're having a POTS flare. Most people chug a tablespoon of salt and drink some fluids, tank up on it, and they feel better. Mast cell flare-up is all of a sudden you're having this severe body-wide pain, everything hurts, all your joints hurt, everything hurts, you're feeling fatigued. That's mast cell activation syndrome. This is the time to take some of your Benadryl and and Pepcid and some of your Cromolyn. This is the time to take it. Mitochondrial dysfunction is another I think it's a very common reason for having fatigue in EDS. Mitochondria are rechargeable batteries, and these batteries don't work well in EDS, especially EDSers with mast cell activation syndrome. The treatment is to try a mineral supplement or mitochondrial cocktail. I can't, because of time, I can't show it right now, but if you Google it, you'll find some of these. They have to be ordered through a compounding pharmacy. Abdominal pain is extremely common. There are at least 2 or 3 reasons that I look at. One is gastroparesis, where the stomach has slowed down. There's a slowing down of the intestines. There's alternating diarrhea and constipation. POTS can cause this, and then diverticulosis and prolapse. But the one that I worry most about is MALS. So of all the reasons that I just mentioned, MALS is a severely painful condition. This pain is usually in the upper belly, right up here, and it increases after eating food almost immediately. They get tired after eating a meal. Any physical activity makes this pain worse. It gets worse with standing. It gets better with lying on your side or lying on your stomach. So these are symptoms of MALS. The problem is that in our abdomen, we have a little ligament called the median arcuate ligament, and through that comes out the celiac artery. And along with the artery, there are nerves that come out. They haven't shown that in this picture, but there are also a bunch of nerves called the celiac plexus that comes out. Now, when people with EDS stand up, what happens is the diaphragm gets pushed down, the ligament pushes down on the celiac artery and squeezes the heck out of it. When that happens, there's restricted blood flow to the intestines. There is also pinching of the celiac plexus, and so they have this horrible, intense pain over that region. The treatment, unfortunately, is a surgical decompression, and I would recommend seeing a surgeon who's very, very experienced in doing this. And there are 2 types of surgeon. There's a surgeon who just goes in there and he releases this ligament, and then there's a surgeon that will not only release the ligament, but also remove the celiac plexus. And between the 2, I think the second surgeon, the results are much better, that remove the celiac plexus. And the results are really good. Even though it's a surgical decompression, it's a surgery, and I'm not a huge fan of surgeries in EDS, but this is one place where it is very helpful, and the results are actually amazing. On a side note, just between you and me, it may help your POTS. Now, the other reason why patients with GI issues have pain is from mast cell activation syndrome. Mast cells cause inflammation of the lining of the intestine. And when the lining of the intestine gets inflamed, the intestine stops moving. And when it stops moving, it starts getting bloated. So obviously the treatment is to take your mast cell medications. The other treatment for getting your gut moving is a drug called Resolor. That's the one that's available in Europe and in Canada. Or it's just recently come into the United States, where it is sold as Motegrity. If you can get hold of Motegrity, then you are the lucky 10 people in the United States. Most of my patients just don't wait for it. They buy it from Canada. A half to a quarter tablet at night may be sufficient. Again, it's really important to understand the cause of pain before deciding on your treatment options. So you might be having belly pain, and all they do is they do a scope from the top, they do a scope from the bottom, and they say, we didn't find anything. So you've got IBS, and which is really a kitchen sink diagnosis. It makes no sense at all. And that's the end of it. Muscle pain, obviously there are lots of treatments for muscle pain, but I'm just giving you the quick and dirty on it. Epsom salt baths are great. 2 large cups of Epsom salt in the bathtub and soak yourself. It has a boatload of magnesium in it, which helps your muscles. You can get magnesium lotion online. That helps a lot. If you can find somebody who can give you IV magnesium once a month or once in 2 weeks, that's also very good. A drug called Cinemet, that's in the US it's called Cinemet, but it's a combination of carbidopa and levodopa. This is much more useful for muscle spasms and cramps. It helps with that. It also helps with restless leg syndrome. But Cinemet is good for cramps, not for regular muscle pain. Periods, there's only one answer to this. Stop your periods. Talk to your OBGYN about stopping your periods. Like stopping, because that can make your POTS worse, your mast cell worse, your pain worse. Everything gets worse. I was asked to talk about ketamine. So a little bit about ketamine. Is a very good painkiller at low doses. It works best when it's given as an IV. It can be used as a nasal spray or under the tongue. Not as good as IV, but it is something. It's only good for nerve pain. It does not work on structural pain. It won't work on joint pain or muscle pain. It'll only work on nerve pain. So it's a duplicate slide. Opioids, reasonable to try opioids. My experience has been that a lot of the EDSs don't respond to opioids, but there are a subset of patients who do respond to opioids, which is fine. It's much better to use it for acute flare-ups, like you had a massive flare-up and your leg is killing you, your knee is really hurting, you can take it. It works much better that way, but you can also take it chronically. Stay at low doses. It works much better at lower doses. At higher doses, it doesn't work as well. For surgical pain, for surgical pain, what I've found out is that dilaudid work is a good option. I have patients with EDS who don't like opioids and it doesn't work for them at all. They've tried the morphines, the oxycodones, doesn't work for them. But strangely enough, dilaudid does work for them. Now, if you're undergoing surgery, you can always ask for your opioid of choice. But if you don't have an opioid of choice, then ask for dilaudid, and it does work well. The problem is that if you take opioids continuously or on higher doses, it can make your mast cell worse, your GI issues worse. So that's why I was talking about taking them as needed. But definitely, it's a good choice to go. Let's talk about opioids and addiction. Is that true? So I looked at the data from the CDC, okay? Only 6.6% of patients are at risk of addiction to opioids at low doses. 0.6%. That means that if you took 100 patients with chronic pain and you gave them low doses of opioids, not even one of them will become addicted. At high doses, the risk is about 6%. That's all it is. So patients with chronic pain are not at risk of getting addicted to opioids. And this is from the CDC. And I'll show you. This is the exact reprint from the CDC. You can look at it at the bottom. This is the exact same thing. I'm sorry, it was 0.7, not 0.6. But this is the exact data. And so the problem is that people don't read this data. And that is the problem. So why is it that we hear so much about opioids and addiction? Number one, for a person to get addicted, they have to be hardwired to addiction. So they have other addictions, alcohol addiction, smoking addiction, or something like that. The media does not care about why the person died. They blame everything on opioids. But if you read between the lines, and if you read them in the news in detail, it actually talks about the person who died had taken, 200 tablets of oxycodone at the same time, had also taken cocaine, heroin, carfentanil, and washed it all down with alcohol, and he died. But no one talks about that. They all talk about that he took oxycodone and he died. They don't even talk about how many oxycodone he took and died. And that has set off a really bad trend. The CDC has not said that opioids cannot be used for pain. They have not. I know the CDC guidelines by heart, and they not in any place have they mentioned. They have said, yes, if you're giving somebody high doses of opioids, be cautious. That's all they've asked for. They just want to see if you're giving opioids to someone, you don't know if they have an addictive personality. So just if they don't have an addictive personality, or you don't know them, as a doctors, we don't know who has an addictive personality. So they said, just be careful, just be cautious that you're not taking extremely high doses. Or if you are taking them, you look for signs of addiction. But the CDC has not said that. The problem is with the medical boards. The medical boards have made it very difficult for physicians to write for opioids. And they don't, again, they said, follow the CDC guidelines. That's what they say officially. But physicians are burdened with immense paperwork and even subtle threats. And that is the reason why doctors don't want to write them. That's the problem that we run into. So the problem is not with anybody. The doctors do want to help their patients in pain. Every doctor wants to do that. But the problem is that the medical board is breathing down their back. I mean, I get an email once a month that tells me these are the number of opioid prescriptions you wrote as compared to the other doctors in my state, which is fine, but I'm a pain specialist, and you're comparing me to an eye doctor who probably has never written a prescription for pain. So this is, but it's like a subtle threat, like, hey, we're watching you. I don't have a good solution for this. You have to go to the legislative section and get this done, but I don't know. Moving on, how do you work around this? Build a trust with your doctor, okay? Don't walk into your doctor the first day and say, hey, I have EDS, I have muscle, blah, 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 and my shoulder hurts, my knee hurts, every joint in my body hurts. I need you to write Vicodin for me. That doesn't work. You have to get your doctor to trust you, to understand you. Start low, go slow. Again, slowly start to build up a trust. Slowly start on an opioid on a low dose, and then go up slowly. Avoid making excessive phone calls and emails because you're about increasing the dose, because that just kind of is considered a red flag. If you're constantly calling, I know you're in pain. I know your muscle might be acting up. It could be your joint is subluxing, but nothing will be gained by sending in 20 emails a day or making 44 threatening phone calls, saying, hey, I want you to double my Vicodin. That kind of just puts the doctors off. You need to gain their trust. Now, here's the other problem. Most insurance companies, actually all insurance companies, deny opioids. That means they will not give it to you. They'll just say, no way. This means that your doctor has to make hours of phone calls and tons of paperwork to get them to approve it, which in most cases does not work. So what I found out was that some of my patients were doing was they have been buying it on cash. And oftentimes pharmacies will have coupons. There are coupons that you can get, and it reduces the price. It's much faster and it's much cheaper. I don't have too many details on this, but this is what I found lately, where patients have said, we can't wait for all this authorization business and insurance companies waiting, taking weeks to get my pill. they just go ahead and buy it. I think that I don't know the prices, but if it's affordable, it might be just easier to buy it with cash. And the pharmacists are very happy to do that because they get their money right away. And oftentimes they'll have a coupon also that'll make it cheaper. Now, before undergoing surgery, this is the important part. Before you go through surgery, talk to the surgeon about your pain management after discharge. And this is a very sore point with me because surgeons will do surgery on a patient's spine, and they give them boatloads of opioids while they're in the hospital. Come Monday, when they're being discharged, they're sent home with the 1 tablet of Tylenol. And you just did a major surgery on the spine, or you did a major surgery on whichever body part, and what you're discharging them with is 1 Tylenol. So you really have to make this clear with your surgeon that I need you to manage my pain for at least a month or 2 months after my surgery. You have to be very clear about that. Marijuana, a lot of people did ask me about that, works well in EDS. It's not as awesome a painkiller as we think it is. It sort of does help. It definitely helps with sleep. It does not affect the mast cell system, mast cell activations. It does not affect the GI system. You should have an equal amount of CBD and THC for it to work. That means you need to have the whole plant for it to work as well. And it has to be marijuana, not hemp. Hemp CBD is not useful. You get better results from CBD and THC. CBD is for pain, and THC is for cognitive effects. And obviously you want more CBD, less THC, and you can balance it out, but you have to have both. I wouldn't recommend smoking it. Tinctures, gummies are a great way to go. They take a little longer to work, but they're a great way to go. You'll have to try it out. It doesn't work in everyone, like every medicine, but it's worth a try. Low dose naltrexone. This is the favorite subject for me because I started writing low dose naltrexone. I repurposed an old drug back in 2000s, and for not for EDS but for nerve pain, and I was finding amazing results. But then I was getting a lot of useless phone calls from physicians asking me what is low dose naltrexone. So we published our first paper in 2012, and now it's becoming more and more mainstream. So without getting into too many details, it helps with pain and fatigue by increasing your endorphin levels. It also helps with healing, which we desperately need as EDS patients. Now, the normal dose is about 4.5 milligrams per day. You can take it in the morning or you can take it at night. Doesn't matter. My preference is morning. If you're not sure, you can start at a 0.5 milligrams. There's a really small dose and increase as you go along. But it's not a drug that works right away. You have to give it a trial for at least 6 months for it to work, for you to decide if it's working. It's not an opioid. It's not an addicting drug. It actually blocks the effect of opioids. And so there are, believe it or not, there are physicians out there who claim that it is an opioid. Not sure which medical school they graduated from. The thing about LDN that I like most is it's a disease-modifying agent. You know, if you take a painkiller, let's say you take Motrin, or you take a Vicodin for pain, it's helping the pain, but it's not modifying the problem. LDN is a disease-modifying agent. It fixes what is broken, and it is not a Band-Aid at all. It helps with chronic pain. It helps with neuropathic pain, autoimmune dysfunction. And I'm getting a lot of reports that it helps with mast cell activation syndrome, fatigue, and brain fog. Some of the practical tips are start at 2 milligrams in the morning for 2 weeks, and then go on to 4.5 milligrams. You can take it anytime you want in the morning or at night, but it has to be one time a day. Some of the side effects are headaches, insomnia, and colorful dreams. They go away after some time. Who can take LDN? Both adults and children can take it. What if I'm chemically sensitive? Start with an extremely small dose, such as 0.1 milligrams per day. We have something called ultra low dose naltrexone, and you can start with that at 0.1 milligrams per day. And then you can build up. You may not need to go to 4.5. You may need to go to just 1 milligram. If it helps, great. If it's not, keep increasing it till you get to that sweet spot. But check with your compounding pharmacy that they're not including any preservatives, coloring agents, or binding agents. Every state has lots of compounding pharmacies. You can go to any of them. My preference are these two pharmacies in Colorado and in Massachusetts, because I know that they're very EDS aware pharmacies, and they understand the chemical sensitivities. But there may be others that I don't know of, but just for you, this is for your help. You've got to take it only once a day. Please do not take it more than once a day. It will not work. I have seen this happen again and again. Please take LDN. You can choose whenever you want, morning or at night, but take it once a day only. These are the fillers. My preference is no fillers at all, but there are other fillers that can be used, Avicel and sucrose and all. But the preference should be to ask the pharmacist, please don't put any fillers, please don't put any coloring agents, please don't put anything that's not needed there. Now, one of the questions I get is, well, LDN blocks opioids. What happens if I have an emergency? Will it work? Yes, it will work, because the number of opioid receptors that LDN blocks is extremely small. Remember the term low dose? So it's an extremely small number of opioid receptors it blocks. So let's say I'm on LDN and I have my leg is fractured and I go to the emergency room. They are going to give me a boatload of opioids. They're going to give me tons of morphine that the LDN will have no effect on it. So it's fine to use it. Now, but what if you're planning on surgery? If you're planning on surgery, then it's preferable to stop at 4 hours. I'm sorry, if you're on opioids, if you're on a short-acting opioid, then you can stop it 4 hours before and take it 4 hours after your opioid pill, and it'll still work. So there have been no reported cases of withdrawal in patients who have been taking LDN and have been given a low dose of opioid. Now, the problem is in hospitals. Number one, most physicians who work in hospitals don't know what LDN is. They don't care to even learn about it. The problem lies in that is that they use electronic medical records, and in the electronic medical records, there is no such dose as naltrexone 4.5 milligrams. The minimum it has is naltrexone 50 milligrams. So what they do is they see low dose naltrexone and they put it into your orders as naltrexone, and it automatically starts dispensing 50 milligram pills. That's where you have to be very careful. The hospital pharmacy is not going to compound it. My suggestion is to talk to the doctor and say, look, please don't give me your naltrexone. I have my own, I'll take it. The other problem that you'll run into is if it shows up, it'll show up on the electronic medical record as naltrexone. It won't show up as low dose naltrexone. Naltrexone was originally designed for treatment of heroin addiction. So the moment they see naltrexone, they start thinking that, okay, you must be a drug addict. That's why you're on naltrexone. That's happening less and less now with more and more information out there. Smart doctors are now beginning to read about LDN and use it, and they know more about it. So it's not I'm hoping this is going to get better eventually. If you're going for elective surgery, stop at 24 hours before and then restart at 24 hours after the last opioid dose. But you've got to take it once a day only. It does come as an ointment. I don't recommend it. It's used for patients with sensory issues and an autism, but it's still better as a pill. Some of the resources, Alien Research Trust has some very credible information. That's their website, alienresearchtrust.org. They have some really good credible information if you want some more. Perioperative care of EDS. So how you're going in for surgery, you're just being told that you're going to have this big spine surgery and what should be done before, during, and after. So there was no information out there. So back in 2020, Dr. Linda Bluestein and myself, we published a paper called Perioperative Care in Patients with EDS. And it's open access. So we did pay for it to be open access, so anybody can get to it. You can always Google it and find it and print it up. Hopefully your doctors will read it. But perioperative care of anesthesia of patients with EDS is a whole different ball game. And people who are going to be taking care of you in the hospital really need to know that. So the concept of exercising in pain, no gain is not, it doesn't work in EDS. It's more about just moving your muscles and gaining tone, not sweating it out. Again, with medicines and exercises, start low, actually start extremely low and go extremely slowly. Service dogs, my all-time favorite. These are amazing creatures. And I can, for those of you who have service dogs, know this, but those who don't have it, and it's something to look at, service dogs can help in a million different ways, depending on what your issues are. It helps with POTS. It can sense an episode of dizziness or seizure even before it happens. It can protect your limb from being injured or touched. It helps boost your confidence because you always have somebody watching out for you. It can help with balance. You can grab onto a handle on their back. It can call for help if you're in a problem, open doors, pull your wheelchairs, and of course, they're always great for anxiety. These are some of the organizations that help with service dogs. This is a book that was published a few years ago called Disjointed. I would recommend reading it. All of it may not apply to you, but the information is very, very, very credible. It's been written by some very credible people, and I would recommend reading it. As you probably know, that there's a lot of useless information floating around on the internet, but this is one of the places where all that was taken out, and people who wrote these chapters are very credible, except for one. Lipedema and EDS. Now, this is a condition that we are starting to understand a little bit more, and so I wanted to bring this up. These are people who have have obesity and EDS, and we're not sure why that happens. This is a condition that causes excess fat to accumulate in the lower part of the body, mostly around the torso and the belly, the buttocks, the thighs, and the calves. And this fat can be painful. And when it's painful, it's called Durkums disease, DERCUM. I don't know if I put it there. This is what it looks like. So you can see lipedema. It's not fat, it's lipedemia. And this lipedemia collects in the lower half of the body. It's not in the upper half, it's in the lower half. And this is not what you think as a regular fat. This is more of if you feel it, it feels like it has a rubbery consistency to it. Why do people have lipedema? We're not sure. Why do people with EDS have lipedema? We're not sure. It can be painful, this fat, and it is associated with joint hypermobility. I've put in 2 websites where there's much more information up there. The Lipedema Society is very into it, and they can give you a lot of information about treatment of this. But here's what the reason for putting this in was, once I need you to be aware of this, okay? Because I have had patients who have been told by doctors that, oh, your joints hurt because you're fat and you should lose weight. This is not weight. This weight is not from fat. This is lipedema. They can exercise till the cows come home and it's not going to go away. I have a woman who swims over 50 laps a day and she still can't lose that weight. And this is more of a lipedema fat that can only be removed by surgery. That's the thing. It may be associated with lymphedema also. This is Durkums disease, where you see these nodules, and each one of these are nodules in the fat, and they're painful. These are called, it's called Durkums disease. And they're painful lipomas, lumps of fat that have become painful. Long COVID, again, long COVID is nothing but dysautonomia or mast cell on steroids. That's all it is. And there are a few other things in it, but that's what it is. These people develop severe dysautonomia. They develop mast cell activation syndrome. There's good and bad news in this. The bad news is, long COVID, people suffer for a long time. But the good news is that there's more and more awareness about dysautonomia, POTS, and mast cell activation syndrome. And I think the reason it lasts a long time is because most physicians are not aware of the fact that this is a dysautonomia and mast cell activation syndrome. The only point I can make on this is that we still don't have great literature on it. Who develops long COVID? Who doesn't develop long COVID? And why? And also, as a side, why do some people have more symptoms from COVID and some just fly through it? And one of the things that we found out is vitamin D levels. People with normal vitamin D levels tend not to develop long COVID, tend not to have severe symptoms of COVID. It's not a definite, but we're starting to get some literature on that. They get paresthesias, pins and needles, belly pain, nausea. These are all symptoms of dysautonomia and mast cell activation syndrome. I'm sorry, that spelling is wrong. Pharmacogenomics. This is that part where somebody had asked, one of the questions that was raised was, why are people with EDS are chemically sensitive? I don't know why people with EDS are sensitive to chemicals, but I can tell you what goes on and what happens and how to solve it. So pharmacogenomic testing is a test that they do. They take a little smear from your inside of your cheek and look at the genes. And there are essentially 6 genes that are responsible for metabolizing all the drugs in our body. So anytime you take a drug, anytime I take a Tylenol, Tylenol is then processed by a specific enzyme in my body and destroyed. But depending on how your body processes or metabolizes these drugs will determine how you respond to them. So they've been divided into 4 categories. The first category is poor metabolizers. Okay, so the medication goes in and does not get metabolized easily. It takes forever. That means the effect of that medicine stays on for hours and days. Those are poor metabolizers. Then you have intermediate metabolizers that are the same as poor metabolizers. Extensive metabolizers are those who normally metabolize their drugs. And then you have the ultra rapid metabolizers. This is when they take a medicine and it's broken down, boom, just like that. So, but these are the types. So we generally have poor metabolizers, normal metabolizers, and ultra rapid metabolizers. Poor metabolizers destroy their drugs very slowly and so have a prolonged effect. Ultra rapid metabolizers burn their drugs quickly, don't really see any effect. So how does this affect us? So poor metabolizers need to take lower doses of the drug. It's not the end of the world. I mean, if you are a poor metabolizer to Tylenol, then you take, instead of taking a full pill, you take a quarter pill. Ultra-rapid metabolizers need to take higher dose. So this person will need 4 tablets of Tylenol to get the same benefit. But here's the problem. Sometimes an ultra-rapid metabolizer may increase metabolism of another drug. Let me give you an example. Say I take Tylenol and I take Motrin at the same time. For the Motrin, I'm a normal metabolizer, but for my Tylenol, I'm a ultra-rapid metabolizer. Now, what happens is if I take them together, my Tylenol, as it's getting metabolized so rapidly, that my Motrin also gets metabolized quickly. So you have to make that dose adjustment. So there are companies that do this test, pharmacogenomic testing, and I believe that most of them are covered by insurance, as far as I know. There are 2 kinds of companies that do this. There's one company that will just tell you which of the 6 enzymes are a problem, which makes no sense to anyone. But there's other companies that will actually tell you which drugs you are on that are being affected, or which drugs are being, or you're an ultra metabolizer for which drug, or a slow metabolizer for which drug, that they'll tell you that. And that's a much more useful information. But to be safe, always start, whether you're a rapid metabolizer or a poor metabolizer, start your medicines at a low dose and go up very slowly. Oxygen supplementation, I threw this in because we have pretty good experience now. We've been doing this for a few years now, about 6-7 years now. It's a long story, but essentially what happens is even though your oxygen saturation is normal, on a microscopic level, there's not enough oxygen getting to your tissue. This is more in patients with brain fog and fatigue. It helps with that. 3 liters to 5 liters, 20 minutes, twice a day or more if needed. This is Cinemet. We talked about this. One of the concepts about exercising is no pain, no gain. We're not looking at that. You're not Arnold Schwarzenegger. You're not going to pump 200 pounds to be in pain in order to get any gain. Somebody wanted to talk to me about microtrauma, which I think is a really good subject. If I get up from my chair and walk a block, I sustain microtrauma. Some small tissue is breaking down. It's invisible, but it does break down, and my body repairs it quickly. Macrotrauma is when you have a fracture or you have a big cut on your arm. That's macrotrauma. But the problem in EDS is the microtrauma. So if I and a person with EDS, we walk around a block, we both come back, the person with my EDS will sustain a lot more microtrauma than I will. That means that person has more trauma. She's suffering from more microtrauma than I am. And it's going to take a lot longer for that tissue to repair than me, compared to me. Some of the things that increase microtrauma are overstretching the muscles and ligaments. Doing repetitive things like vacuuming, chopping food, dusting increases microtrauma. But it's not something that you can avoid, but you just have to be aware. And that is the reason why I say exercise under your limits. So this is an example of a microtrauma. And you can see over here that this tissue, there's been small breaks in the tissue, muscle fibers here. Let's talk about exercising in EDS, because there's a lot of misconception about this. You're looking at toning your muscles, not strengthening your muscles. That's the difference. So strengthening is not a great idea. Strengthening means that I start doing, I pick up a weight and I start doing bicep curls till my biceps become big and huge. No, we're not looking at that. You're going to pick up the weight and maybe do a few of them, a very, very lightweight, do a few of them so as to keep the muscle toned. So the muscle is pumping, the muscle is moving, and it's greased up, to lack of a better term. Because if you start pumping muscles to strengthen it, you're causing more and more muscle micro trauma, and that micro trauma is going to set you back. You won't be able to exercise for the next week. Other exercises that you can do are proprioceptive exercises. It's more important to exercise consistently. So when you go to your physical therapist, it's twice a week. But that doesn't mean the rest of the 5 days you can sit back on the couch. That won't work. You have to exercise on a very consistent basis. I look at physical therapists more as teachers. They guide you, they teach you, and then you have to do your homework. Avoid joint loading or joint stressing, which means avoid jumping, running, and focus on muscle toning rather, and absolutely no stretching. Oh, your rotator cuff muscles are really tight. Let me stretch them, or let's just stretch them. No, they're tight because your shoulder joint is probably subluxing, and that's the reason why they're tight, and they need to be tight to keep your joint stable. The treatment would be to help with the stability of your joint, not make your muscle more, stretch your muscles more. This is a repeat. This is to show you, also keep your limbs under your range of motion. So for example, I can bring my shoulder up here. In EDS, you bring your shoulder joint up till here. You can bring your elbows out. In EDS, keep your elbows bent a little bit. So in this case, the person can bring his leg out to a full 140 degrees flexion. Stay under. So you don't want to go, you want to stay, you stop short at both ends. So you stay within the middle of your range of motion, because at either end, you're going to overstretch your ligaments. This is the best aquatic therapy. Contact with skin helps your brain with proprioception. You weigh less, so you're not putting any load on your joints. So you can exercise your muscles better, which means you tone your muscles better. I would avoid swimming. Other than breaststroke, no, all other strokes are not good for you. For example, in this case, this person's shoulder joint is going to get loose and lax. The neck joints are going to start getting unstable. So I don't recommend this stroke, but a stroke that is more gentler, like a breaststroke, is much better. Or simply walking in water or treading water are good ways to exercise. Feldenkrais method, if you can find, I believe this is becoming more and more common, easily accessible, because of now there are people offering Feldenkrais techniques online. So that's really good news. It's a great way to exercise. It does not put any strain on your joints. It does not put any strain on your muscles. It's very gentle, it's slow, it's repeated movements. If you can find a Feldenkrais practitioner in your area, that would be great. If you can't, then look online and you'll find them there. I'm not sure that website is still valid, but have a look, feldenkrais.com. CGRP antagonists, we're coming to our end, I promise. CGRP antagonist is a new class of drugs that have come out, and I have high hopes for it. Right now it's only approved for treatment of migraines, because that is what the research was done on. It has literally no side effects, but research has shown that it can work on nerve pain, because when a nerve gets painful, it releases CGRP, calcitonin gene-related peptide, and so blocking that does help. So I think it won't be long before CGRP antagonists are approved for treatment of nerve pain and other pains also. Currently, there are a lot of them, but the current pills that I could remember was Nurtec, Ubrelvy, and Qulipta. How do you talk to your primary care doctor about your EDS? You don't talk to your primary care about your EDS. Let your primary care doctor do what he or she does best. Take care of your mammogram or your pap smear and all of those things. Don't bug them with the EDS. They don't have the time and they won't be able to do it. Definitely keep them updated. Just tell them that, hey, I went to the POT specialist. This is what he or she recommended, just letting you know. So definitely keep them updated. Make sure you see an MD only. We have had a lot of issues with patients being seen by residents, interns, medical students, nurse practitioners, physician assistants who have no idea about EDS. I mean, even the doctor doesn't have any idea about EDS, but at least your doctor getting to know you makes a lot of sense, because I've seen these people that I just mentioned recommend wrong treatments, leading these patients into a lot of trouble. They give them wrong treatments. They assume that GI, they go in there for GI issues. They're given wrong treatments and they end up in a lot of trouble. So make sure you see a physician only. Electronic medical records, I just discovered, I don't use this thing, electronic medical records. It doesn't make sense to me. But anyway, they're good for sharing information between your doctors. But the problem is that they also share not only good information, but they also share bad information. So if you go to a doctor and that doctor puts in your medical record that this patient has been vomiting and therefore I think she has an eating disorder, this is going to get passed on to every subsequent doctor you see across the country, not just your country, your state or your town, across the country. So you do have an option. You can ask them to, but you can ask them that my information should not be shared. My medical information should not be shared with anyone without my permission. Because I've had problems where some bozo diagnosed this patient with gastroparesis, with an eating disorder. And after that, every subsequent doctor she went to said, oh, you have an eating disorder. And I couldn't understand why are they all saying the same thing. And then I realized that it shows up on the electronic medical record, but there is a way out. You can ask your doctor not to share your information with anybody without your permission. So we end this with two good resources that I do recommend. We talked about the book Disjointed. There's a website, it's called chronicpainpartners.com. And there are some really awesome webinars and lectures on it by really good experts that I would recommend listening to. So these are the two good resources. And with this, I think we should shut down. Thank you very much for being with me.
Thank you, Dr. Chopra. I think that is wonderful information, incredibly thorough presentation, so much information. I know that Danielle has been reporting it. I think I don't see her jumping on again, but I know for sure we both talked about it while you were talking, that we really will encourage people to re-listen. Those that either had to leave early or those of us that have stayed on for the entire time. You gave such a wealth of information, and it is a lot to digest, but most importantly, to understand the biology of our bodies and why things happen and why certain things work and other things don't. So we've gone over. I hate to ask you for any more questions, and I think you've kind of been more thorough.
Kendra, there are only 4 questions, and I can take care of them real quick.
Okay, all right. So I'll ask
only 4 questions. The first one is from Megan. Can the tendency towards central sensitization contribute to any of the causes of headaches in EDS? And the answer is kind of yes. I did have slides on central sensitization, and there were like 15 slides. And I took them off, thankfully. Otherwise, we would have been here till tomorrow morning. But central sensitization happens in patients with chronic pain, and so it can contribute to headaches. Let's say, Charlotte, let's say neither lidocaine nor Marcaine works. What would you typically try next? That's a tough one. There's carbocaine that you can try, but there are not that many choices in terms. We don't have any studies on this to see what other. We have, for the first place, we don't even know why lidocaine doesn't work. And why does Marcaine work? And so we don't really have any other information on that. But carbocaine is another choice that you can look at. Is tethered cord the same as cauda equina? It seems to have the same symptoms. No, it is not. Cauda equina is an emergency, and it is not the same thing. It is completely different. And if somebody gets diagnosed with cauda equina, that's depending on when they were diagnosed, that is an emergency. I would be careful. Is there any sort of strengthening exercises that can be done to have with rib pain, since it seems that it stems from poor posture? No, unfortunately not. You can, I mean, yes, you can do some core strengthening exercises that'll help you, but poor posture has nothing to do with you. It's just that your ligaments are loose and lax, so you tend to bend forward. So I think between strengthening your core muscles and wearing one of those compression garments would be your best choice. There you go, Kendra.
All right, there was one more last question. It just says, what is the name of the company with the pants that are good for EDS?
Oh, I didn't miss that. Yeah. Oh, it's the same. CW-X.
CW-X. Okay, and we'll make sure that we also.
Well, both DM Orthotics and CW-X make them, but Leonisa does not. Leonisa is more on the upper body, torso part. But for the legs, I would definitely, I showed you the picture on the legs one. Those are CW-X. It's like an exoskeleton.
Yeah, I know. I have some of those garments myself personally, and I use them. They're great.
Yeah.
So, all right.
Well,
go ahead, Danielle.
I just wanted to thank you, Dr. Chopra, for such a great, fascinating presentation that it will help so many people, whether somebody's just new with EDS or whether somebody's had EDS for quite a while. This will be excellent for them. So, and we appreciate all your time on a Sunday evening.
You're welcome. My
Yes, thank you
pleasure.
so much. And we'll get the slides as well, to, as you mentioned before, to help complement the recording. So thank you again, Dr. Chopra. It's wonderful to see you as always.
Take care. Have a good night, everyone.
Thank
Thank
you.
you.